go to the slides. So the goal today is really mostly to discuss interesting cases, but I'll just give a brief overview regarding upper cervical spine injuries, and we'll go directly into the cases. Dr. Molinari is going to present 2 cases, and I have 2 cases to present after that if time allows. So we know the upper cervical spine, or the cranial-cervical junction, is made up of both the bony structures and strong ligamentous attachment. So there's the occiput, the atlas, which is C1, the axis, which is C2, and this structures, the bony structures and the ligamentous attachment, protect the upper cervical spinal cord, the brainstem, and the lower cervical nerves. Injury distribution is bimodal, so you typically see this in much younger kids, so in children, and in adults age over 60. So cervical spine injuries in children account for 1 to 9% of all pediatric spine trauma, and upper cervical spine injuries in children account for 56 to 73% of all cervical injuries in children. 56% of them have concurrent head injury, with mortality rate reported up to 41% when concurrent injury is associated with a cervical fracture. In the upper cervical spine, in adult over the age of 60, C1-2 injuries account for 69%, with odontoid fractures accounting for 57% of all upper cervical fractures. Mortality rate reported between 26 and 28%. Here's just a diagram demonstrating all the different ligaments involved with attachment of the occiput to C1 and C2, providing the stability and protection of the brainstem, the spinal cord, and the nerve roots, as I previously noted. So occiput C1 articulation supplies approximately 50% of total cervical flexion and extension. As you see, this is pretty significant function at that level. And this is when we think about treatment, especially when we consider surgery, including fusion, you see how much limitation this can lead to with immobilization from fusion. And at C1 to articulation, you get about 50% of total cervical rotation. In patients presenting with upper cervical fractures, you go through your routine trauma evaluation with your ABCs. Injury can often, or fracture can often be missed if adequate imaging is not performed, or if consideration is not, if you don't take into account the mechanism of injury and the patient's mental status. High suspicion, you should have a high suspicion for upper cervical fracture in patients with facial fractures and head injury. Vertebral artery injuries is reported between 18 and 24% with upper cervical spine fractures. As I mentioned, it can be difficult to evaluate. There's no specific myotomal or dermatomal distribution, and we have a couple of case examples where you can see how a more significant injury can be easily missed. There's limited use of plain radiographs in evaluating these patients. CT is the most sensitive to evaluate fractures. With a cranial-cervical junction, injury is not, as it doesn't necessarily, is not always associated with a spine fracture. I'll give you an example. I've seen in practice now 3 patients with occipital cervical dissociation, and only 1 patient truly had a bony fracture. The rest of the patients, the other 2 patients only had ligamentous injuries. MRI is most ideal to evaluate soft tissue injuries when evaluating for spinal cord hemorrhage, ligamentous injury, injury with a disc, and MRI is also comes in very handy when you're planning for cervical collar clearance in obtunded patients. As you know, the goal is to try to avoid maintaining some of these patients in the cervical collar if they don't truly have an injury. As you know, for patients who are obtunded or not alert, the cervical collar itself can present issues with a pressure source over the skin, since the patient can report concerns with their collar. What are some of the common upper cervical injuries that we see? Atlantoaxial subluxation or dislocation. In children with symptoms less than 1 week or presenting less than 1 week, soft collar and observation. Those presenting 2 to 4 weeks, hospital admission and head halter traction. And for greater than 1 month, you have to consider skull traction for about 3 weeks, and also consider C1-2 fusion if there's failure in management with traction. Another common injury that we see is, especially at the level 1 trauma center, is transverse ligament injury. And how is this evaluated? It can be evaluated from an open mouth odontoid view X-ray, looking at the atlantodens interval from a lateral perspective, looking at a lateral X-ray. The anterior atlantodens interval greater than 3.5 millimeter in adult and 5 millimeter in children, or lateral dislocation in open mouth odontoid view with a total overhang of greater than 6.9 is considered a transverse ligament injury and can be confirmed with MRI. Type 1 injuries, intrasubstance injury, and you have a type 2 injury, which can include avulsion injury with tubercular insertion of the transverse ligament. And as we go over the different common types of upper cervical injuries that we often see, one thing to keep in mind is these injuries can be associated with fatal injuries, or it can be associated with and the range of neurologic injury can range from your typical whether it's dermatomal or myotomal pain, or it can range to quadriparesis depending on the extent or how severe the injury and the mechanism of injury. C1 fractures account for from 2 to 13% of all C-spine fractures and 25% of all injuries in the atlantoaxial complex, typically from motor vehicle collision or fall onto the head. 50% of is associated with dense fractures, and one of the cases I'll present has an associated dense and C1 injury. Hangman's fractures, C2 teardrop fractures, and but neurologic injury is quite uncommon given the pattern of the fracture, as most of the time the fracture lends itself to actually increase in the dimensions or in the diameter of the spinal canal, which and hence not a spinal cord compression. Occipital condyle fracture is also another fracture that is often seen in the upper cervical fracture, especially if you work in a level 1 trauma center. Minimal deficit, it can range from minimal deficit to quadriparesis, neck pain, torticollis, headaches, impaired mobility. So imaging is key to diagnosing, including CT scans and MRI. Occipital cervical dissociation is also another common injury. That is also another injury, not I wouldn't say common. I think having seen three in my 9 years of practice, I would consider a significant number, as most people often tell you they've never actually encountered or seen one. So incidence ranges between 5 to 8%, and 13 to 35% of them result in death from C-spine trauma. It's typically a high energy trauma. You have different classifications. There's a Trinalis classification and a Harbor-View classification. Type 2 dense fracture is the one we think most of us can say we've seen. Patients with type 2 dense fracture in the elderly patients is also a very common upper cervical spine injury, with C2 dense fracture accounting for 15% of all cervical fractures in adults. It's most common in patients over the age of 65. High incidence of morbidity and mortality. There's limited healing potential for type 2 odontoid fractures, with non-union rates reported up to 85%. Traumatic spondylolisthesis or hangman's fracture is also another injury that I would say, working at a level 1 trauma center, we often see with mechanism often involving a combination of extension, flexion, distraction, axial load, with fracture line typically exiting through the neural arch of the axis. Here's just a quick schematic of the demonstrating the classification of traumatic spondylolisthesis or hangman's fracture. So as I mentioned, majority of the time, given there's no myotomal or limited dermatomal distribution, this injuries can often be missed, especially when we talk about spinal cord compression. Given the fracture patterns that we see, whether it's in the occipital condyle or at C1 or C2 or ligamentous injury, for patients who are presenting without gross paralysis or quadriparesis associated with a fracture, They may present with neck pain, which sometimes the question is this really related to neural element compromise, or is just from a traumatic injury or contusion from the fracture? So we have a few cases to present that would address patients who are actually presenting with symptomatic spinal cord injury. In a couple of cases, it's a delayed presentation after the injury, which subsequently progressed to spinal cord compression and with symptoms. So I'm going to turn this over to my partner and mentor, Dr. Molinari, to present. He's going to present 2 cases. And depending on how we're doing with time, I also have 2 other cases to present.
Thanks, Emmanuel. Okay, good evening, everyone. Can you see my slide?
Yes.
Yep.
Okay, so I'm going to show 2 classic cases of upper cervical spinal pathology injury patterns. One is a classic translational injury, and one is a very bizarre distraction injury. So let's start with the classic translational injury. We take a lot of call, Emmanuel and I take a lot of call at the University of Rochester. It's level 1 trauma center, as he said. And we see a lot of traumatic injuries, and we see a lot of unusual pathology at the upper cervical spine. And this is one 80-year-old lady who came in. She had a several-week history of neck pain, intermittent, but started to get worse over the past week. And then she had progressive weakness and inability to walk. So she had this acute onset of inability to walk over about 2 to 3 days. These were the x-rays that were taken in the emergency department. And here's her CT scan. And you can see on her CT scan, she has that classic rheumatoid erosion of her odontoid and translational instability at the C1, C2 complex. And Emmanuel talked about the importance of the transverse ligament with C1 injuries. And this is an injury where it's compatible with incompetence of the transverse ligament because there's essentially no odontoid here. So you have subluxation of C1 on C2 with obvious cord pathology. So in this case, this woman was taken to surgery. She had a posterior C1 laminectomy and a simple C1, C2 fusion. And this is her 6 weeks post-op. She regained her ability to walk. Here she is 2 years post-op. And here's the post-operative MRI, where you can see she had some myelinatia in the region of the translational instability, but she's nicely decompressed and stabilized with reduction of the C1, C2 complex. So in my opinion, this is a classic C1, C2 translational instability, similar to the odontoid fracture, similar to the transverse ligament rupture. It typically gets treated in the same manner with a classic posterior C1, C2. In this case, we used a Harms technique fusion. And that's what she had, and she did well. So any questions on this case of what I consider to be classic translational instability of C1, C2?
How did you guys immobilize her afterwards? She's got crappy rheumatoid looking bone, but the nice thing about this fixation, it grabs, it's the best bone that you're going to get in bad bone. But what do you do post-op for helping that fuse and not fall apart?
It's funny, Jack, people talk about the importance of a collar after cervical fixation, but no one's ever shown that. No one's ever shown that that's really important in the literature. And I'll tell you, I've been doing trauma now for almost 30 years, and I don't immobilize my patients that I put fixation in, even these rheumatoid patients. Believe it or not, you get bicortical fixation at C1, you get good screw fixation in C2. It's at an angle where they're not completely parallel to each other, so it's difficult for them to pull out. So I really have not had a problem with just putting the fixation in, putting my bone graft in, and not using the collar just for comfort post-operatively. Emmanuel, what's your thoughts on that?
I think with time, I've become more liberal with the collar. I still place patients in collar, but I advise the patient they can remove the collar for hygiene, for nutrition, and otherwise, I advise patients to wear their collar as often as possible.
Any other questions?
There's a question in the chat room about your strategy for a C1, C2 fusion when you do a C1 laminectomy, whether you kind of worry about the connections above when you remove the C1 lamina?
So I wrote a great paper on, I think it was a great paper on intentional sacrifice of the C2 nerve root in elderly people. And I've been using that over the last decade and a half, where I'll sacrifice the C2 nerve root over the lateral mass. And if you pull the paper, you'll see, I think it's in the journal, maybe in the European Spine Journal, but it shows intraoperative photographs of how you see both lateral masses really well. You see the joints very well. And the placement of the C1 screws is very easy because you see the entire lateral mass and you know where the midline is just by palpation. So in this case, where I did the C1 laminectomy first, I did put the screws in after the laminectomy, but I exposed the entire lateral mass with sacrifice of the C2 nerve roots.
Hey, Bob, another question from the chat. They said, did you use iliac crest bone, and where's the fusion surface?
So it's funny, you know, Rick, I always used to use iliac crest bone about 20 years ago. I would make a separate incision and do it. And then one time in the middle of the night on an 88-year-old, I got into the artery. I got into superior gluteal artery in the middle of the night and, you know, had some issues with that. So after that, I just started, as I sacrificed the nerve root, you can burr the joint out with your burr. And I just been using a little bit of allograft. And believe it or not, it really hasn't been a problem for me. Again, we've published extensively on C1, C2 fusion surgery for geriatric odontoid fractures. I think we have one of the largest series in the countries from our institution. And again, with very little failure, with 2 to 5 year follow-up. So I'm not so sure these fuse solidly, but the fixation is stable and the C1, C2 complex is stable. So it doesn't appear to be an issue regardless of what you're using as your bone graft.
Now, there's one question just came up again. They said, what about reduction? Or did she just reduce with the positioning?
So this reduced, believe it or not, you have to get your monitoring, but before you're going to position any patient with symptomatic spinal cord compression or any spinal cord compression in the cervical spine, you have to get your baseline somats and motors before you position your patient. And then we had that. And then once I had that, this just reduced when I put her in neutral on the table. But if it doesn't reduce, you know, there's a technique where you can put your C1 screws in and actually gently pull on your C1 screws posteriorly to reduce the complex. But again, I think reduction is really not all that important. It does make the surgery easier to put the C1, C2 screws in when the complex is reduced. It is a little bit more challenging when C1 is sublexed to put your lateral mass screws in. But I don't think appropriate or accurate reduction of C1, C2 is really that important. What's important is removing the compression off the spinal cord and stabilizing C1, C2 so it doesn't move and further compress.
Great, thank you.
Any other questions? If not, okay, we're gonna talk about the second type of injury that occurs in the upper cervical spine, which is distraction injury. And, you know, over 20 years here, I've seen, you know, many occipital cervical dislocations. I would say probably about 10. 10 is many, as Emmanuel pointed out. I think he's seen 2 in 6 years. I've seen about 10. So they do come in. And when they come in, the biggest problem with these is how to position them on the table. So what I'm going to show now is not the occipital cervical distraction injury, but another atypical injury that I saw in the upper cervical spine, which is very rare, but the concepts are similar. So a 29-year-old male who was riding a motorcycle. He was involved in a high-speed motor vehicle accident, and he comes in with neck pain. He's taken from the field. He's intubated in the field, okay? But before he was intubated, he was conversant, and he said, you know, he had just some numbness, and he was moving his arms and his legs. He had a broken radius, a tibia fracture, and a pulmonary contusion. And here's his initial CAT scan. And I tell you, this is someone who's moving his arms and legs in the field and was awake and alert before he got intubated. So if you look, this is a variant of the occipital cervical dislocation. And these distraction injuries can occur most commonly at the occipital cervical junction, but they also can occur at C1, C2, and that's because of the accessory atlantoaxial ligaments that can tear. But it's not only C1, C2, as this case shows. It can occur at almost any cervical level, and the other most common level is this C3, 4 level. So we got an MRI on this patient, and you can see there's no cord signal change whatsoever, but the only thing holding the head on the spine in this case is the spinal cord, as you can see from the MRI. There's significant gapping. You can see the posterior longitudinal ligament injury here. There's significant gapping of the posterior ligaments and the anterior disc space. So I think this is a challenging case, okay? And the first thing that came through my mind as the doctor on call is, what are we going to do here? Our orthopedic colleagues are trying to push to go to the operating room to treat the polytrauma. There's a broken tibia, there's a broken radius fracture. And the question is, how do we proceed with this? What's the appropriate thing? So if you think about your options, a lot of different options here, right? A lot of different options. Do you put the patient in a halo? Do you just put him in bed? We had a physician here years ago who just used to put a lot of fractures in rotorest beds and rotisserie them, and he would keep them there for weeks at a time. And I think if you immobilized anything for weeks at a time, it would heal, but it's not necessarily the best option for patients, as they can get pulmonary issues, they can get decubiti, and psychologically, it's a burden for someone to rotate into bed for such a long period of time without movement. So the question is, what's the best treatment option here? So posterior stabilization, anterior stabilization. I'll slow this out to my colleagues here to see how they would recommend treating this case, because I don't think there's a simple answer here. Anybody want to provide some thoughts on how you would recommend treating this? Anyone in the audience? I'm going to show you what I did. This is my last case for tonight, but if does anyone have any comments on how they would treat this?
I mean, these are the toughest cases that trauma surgeons of the spine handle. It's total instability with a functioning spinal cord. So, you got the diciest situation in your square of logic. So this is 100% soft tissue injury, unless the CT showed something different. But this is something I think you've got to stabilize. You can't rely on this to heal on its own, particularly with a functioning cord at risk. So, your responsibility, as you're about to tell us, starts with maintaining the alignment and putting the patient on the table in the right way. And for me, I think this is going to be an anterior posterior fusion. But again, this is of all the quadrants that we take care of, this is the one that constricts your coronary arteries the most.
Yeah, so Jack, I agree 100% with you, right? What you don't want to do here is paralyze your patient, right? You have someone who, for the most part, is pretty much neuro intact, has a normal signal in the spinal cord, and has essentially no support around that spinal cord. So for me, I think the most difficult part of this case was deciding how to approach this without paralyzing the patient, right? And I agree 100% with Jack that I think, and there are options, do you reduce this? What do you do? There are different options. But I think the first question that comes to the trauma surgeon's mind is, how do we stabilize this without harming the patient? And, as we all know, the occipital cervical dislocations, we do those posteriorly. And for me now in my career, the most challenging part of that case is positioning the patient. And what I do with my occipital cervical dislocations is I bring the patient in, I use the spine board, I slide them onto the flat Jackson table. So essentially their neck still remains in the neutral position. And then what I do is I put the other part of the Jackson table on top of them with the Mayfield head holder. So I attach the Mayfield head holder to their neck and their head when their neck is in and their head is in the neutral position. So I lock them in on the rotisserie, on the Jackson table with in the sandwich type configuration, and then I rotisserie them to the prone position. So that's how I try to prevent motion in the occipital cervical dislocation going from the supine to the prone approach. I use, as I said, the Mayfield with the Jackson table in a rotisserie manner. But I didn't do that here. I thought this was much easier just to do, as Dr. Ziegler said. I slid them over to the flat top Jackson table, and I did a simple anterior approach. I had my ENT colleagues help me because, again, it's a traumatic situation. You don't know what's torn. You don't know the state of the esophagus. And we did this at about 4 o'clock in the afternoon, ENT exposed for me. And I did try to reduce this. I actually put a cast bar pin in C3 and C4, and I gently tried to compress down on the disc space to create the normal anatomy of the spine. And lo and behold, when I did that, I lost all my monitoring potentials. So I took my compression off, let the spine breathe a little bit. My monitoring potentials came back, and I just let the spine lie where it was. And I put a cage in with allograft and essentially lengthened his spine. And this was the first stage of the operation. That's all I did. I sent the patient back to the ICU that day. And I brought the patient back 3 days later and did a posterior stabilization procedure only without a decompression. And you can see 5 months later here, patient's neurologically intact, is a little taller. But again, I didn't incur a deficit, have a nice stable construct here. And this patient is now several years out and got married, had several children, and is back to work. So I present this case as a distraction type injury. It's an atypical distraction type injury, but it certainly makes one think about how to approach these injuries and how to do it in a logical manner. So any questions on this case?
Yeah. So why do you think, so he got stretched out and you were just attempting to reduce him, put him back the way he was. And I'm just trying to think anatomically, what is going on that is it just that you stretched and, tore? I don't know. It doesn't make sense that as you tried to reduce him that he would lose signals because, he looks pretty clear on the sagittal MRI scan there.
Rick, I think I buckled his spinal cord. I think I buckled the cord when I tried to reduce this. Again, I think he's lengthened here. He's lengthened here the length of another vertebral body. And I think I buckled that spinal cord. And I think that spinal cord probably has a little bit of injury in it, doesn't like any motion to it, but I definitely incurred a spinal cord injury when I tried to reduce this. And again, I said in my other case with the translational injury, I'm not so sure the reduction really matters all that much, as does the stabilization. The stabilization is really the most important part of this procedure, and stabilization without doing any harm to the spinal cord.
Yeah, well, that's a fascinating case because your natural inclination is, okay, I got to get it reduced, get bone on bone, and then, as you said, come back a couple of days later and do the posterior. But that's a great case, very instructive.
Any other questions? Pure distraction injury. If not, I'm going to turn it over to one of the best partners I've ever had in my career, Emmanuel Menga.
No, thanks, Dr. Thanks, Dr. M. Great presentation. Every day I tell everyone I continue to learn from you every day, and really have been proud to have you as a partner. I have you as a mentor since I was a medical student, and have you as a partner now. So I'll move forward with 2 cases of mine, if we can get to them. The first patient is a 67-year-old female who initially, so she sustained a fall. She said she was walking her dog and the dog pulled her, a tiny little dog, and initially presented to one of our colleagues. We have a great relationship with our neurosurgery colleagues. So initially presented to one of our neurosurgery colleagues, and was from there subsequently referred to one of my other senior partners, because my other senior partner had performed corpectomy surgeries on her. As you can see on the images onto the AP and lateral views, you see previous evidence of anterior cervical corpectomy from motor vehicle accident and trauma. And so after being referred to other partner was ultimately ended up in my clinic. And this 2 months after her neck injury with occipital, when she presented, she reported occipital headaches. She very, very poor historian. The way when she reported her symptoms, even her and I joke about it right now, that when I met her, I told her we're going to get MRI, but I'm not sure if I have any surgery to offer her based on the symptoms she was reporting. Because she reported occipital headaches, radiating pain to the right scapular, right shoulder, right ulnar, and radial forearm, numbness and tingling throughout the entire right hand, gait instability. So the symptoms really didn't make sense. And the CT scan showed a small odontoid fracture. She had a past surgical history, as I mentioned, of a C5 and C6 corpectomy with C4 to 7 fusion with as you see, with a strut graft, uninstrumented fusion. This was done, I think, over 20 years ago. So this is a more close-up view of the x-rays when she presented to my clinic. As you can see, and as I mentioned, when we discuss imaging of the cervical spine, x-ray can be very limited. So even though the CT scan showed a C2 fracture, it's not clearly visible on the x-ray, especially for someone who's had multiple procedures performed in the cervical spine before. Here's just a broad scoliosis x-rays that were obtained when she initially when she presented to us. Some degenerative scoliosis not related to her current symptoms. Here's a CAT scan. She had 2 months. She had 2 months prior when she initially presented, and you can see the odontoid fracture with angulation of the fracture directly through the neck of the odontoid type 2 fracture. And as you can see, there's some angulation, but you don't really appreciate any significant translation of the fracture to be concerned about spinal cord compression or even nerve injury contributing to her symptoms. As I mentioned during my initial presentation, some of these injuries, type C2 fractures, can also be associated with posterior arch fracture or neural arch fracture of C1. So as you can see on the axial view, you see a fracture of the posterior arch of C1. It's just scrolling through the images. So an MRI, the patient was referred to obtain an MRI given the symptoms she was describing, especially with the radicular-type symptoms and also with the gait instability, just to ensure the patient did not have any spinal cord compression, even though I had low suspicion given her fracture angulation and no at least bony or CT evidence of any stenosis. So recommended an MRI. Unfortunately, I think about a week or 2 weeks later, she presented to one of our other satellite hospitals with a fall, progressive weakness, and respiratory distress. And coincidentally, she actually, when she presented, a neurosurgery colleague who had initially referred the patient back to orthopedics was on call and saw the patient. And during her presentation, as you can see, her physical exam had changed quite significantly. When I saw her in clinic, she had full strength, 5 out of 5 strength throughout the bilateral upper and lower extremities, and no significant physical exam findings during her presentation in clinic. So this is 2 weeks later, and she's developed severe weakness in her deltoids, throughout the bilateral upper extremities, and also in respiratory distress and with recent fall. So an MRI was obtained while she was in the hospital at one of our satellite hospitals, and this is the MRI. Scrolling through the MRIs, you can see severe stenosis and spinal cord compression just at the occipital cervical junction. So she was admitted to the hospital and intubated to protect her airway because she not only was she reporting the respiratory distress, her saturations were not great. So she was intubated to protect her airway. This was on a Sunday, and I was contacted, and we had the patient transferred to our level 1 trauma center where I plan to do surgery on Monday. And this is just the intraoperative view after positioning the patient to localize the surgical site. We perform instrumentation extending from C2, from C1 down to C3. Why do we go down to C3? The patient already had a rigid fixation. The patient already had a rigid fixation and previous fusion extending to C3 level below. So I didn't want to stop the fusion with right adjacent to a stiff spine, and so the lateral mass screws were extended down to C3. Here's the postoperative. I just saw her in clinic for she's now roughly I think about 4 months out from 6 months from surgery, and this is the X-rays that were obtained when I saw her in clinic just 2 weeks ago. Any questions or comments about this case? All right, I'll move on to the next case. So 68-year-old male sustained a fall. This is actually one of our primary care partners here at the University of Rochester. The patient sustained a fall onto his neck. He said he woke up and he felt drowsy and he fell down and was found down several hours later past medical history significant for prostate cancer, presented to the emergency department, and the patient was found to have this fracture through the neck of the odontoid and extending into the lateral mass and of C2 on the left side. Treatment options were discussed with the patient. I just wrote through the CAT scans here. So he's a common unit fracture. He was completely neurologically intact. No significant neck pain. So treatment options were discussed with the patient, and the patient opted to proceed with treatment in a rigid collar. We discuss immobilization in the collar. We discuss halo vest immobilization. We use that quite a bit here, and we've had significant success in the appropriate patients. And we also discuss fusion surgery, but he's a practicing primary care physician, and he opted for hard collar. Unfortunately, the patient was non-compliant with the collar, sometimes actually presented to clinic with the collar either upside down or worn backwards. But did, after 3 months of immobilization, the cervical collar, the collar was discontinued. Despite poor compliance with the collar, he really did not have any significant symptoms, and he went on his way. Here's X-rays with collar, with treatment with a collar. As you can see, there's been some translation and some settling of the fracture. So 6 months after his initial injury and non-operative treatment, the patient presented with symptoms of gait instability, dropping of objects, difficulty with fine motor control, numbness and tingling over his bilateral hands, and MRI of the cervical spine was obtained, given he was presenting with symptoms concerning for cervical myelopathy. And here's the MRI that was obtained. And you can see the settling and angulation of the fracture with severe spinal cord compression all the way to the base of the skull. Here are the critical slides. So we discussed surgery, and a CT angiogram was obtained, and here's a CT angiogram. I think we'll open this up for discussion if anyone has any questions or any comments as to how they would manage this. Unfortunately, I think I showed a slide already, but any comments on how you would treat this?
Well, he said, he's settled in his C1, C2 articulation is settled where he had the fracture. So, that joint is screwed, and he's got the odontoid non-union and the compression. I think your hand is kind of forced. You've got to do C1, occiput C1, and maybe C1-2 decompression and stabilization. He's made his decision, but in retrospect, it was not a good one.
So this is translational instability, right, of the upper cervical spine, but this is a little different, Emmanuel, because you have stenosis there. Some of it, I think, was pre-existing, but you have tight stenosis up at the C1, C2 complex. So this, I think, is going to require a decompression in addition to a stabilization procedure. So if you go back to the MRI, you can see exactly where the extent of the compression is. So, looking at that, you look at it and say there is some compression up into the foramen magnum. So this may need a foramen magnum decompression. And if that's the case, you may need more than just a C1, C2 fusion. You may have to include the occiput with this. So again, if you look, there's stenosis there at the upper C1, C2 complex that extends rather high. So I think you're going to have to take the ring of C1 off here and do a nice wide decompression.
All right. Yeah. Someone also asked a question about fixation to the occiput. So as suggested by a panelist, a discussion was had with the patient. I referred the patient to one of our other neurosurgery colleagues as a co-surgeon to manage the patient. We had an extensive discussion regarding instrumentation level. I think certainly everyone agrees, as Dr. Molinari mentioned, that this patient needs decompression into the foramen magnum. So the patient met with one of our neurosurgeons who was going to join me with the surgery. And we went back and forth about fixation to the occiput. As I presented what at the start of the talk, we talked about range 50% of flexion extension at the occipital cervical junction, and also 50% of rotation at the C1-2 junction. So we know that will be a significant limitation with his ability to flex, extend his cervical spine, and also with lateral rotation. So we discussed and opted to take the risk of fusion without going to the occiput. And a discussion was had between myself, the neurosurgeon, and also with the patient. And we opted to proceed with Dr. Silverstein perform what we called a Chiari decompression, so decompression of the brainstem, and also decompression of the occipital cervical junction. And we placed lateral mass screws at C1, pedicle screws at C2, and C3 screws because of its poor bone density, and also for adequate fixation. As Dr. Molinari mentioned, so I typically would sacrifice the C2 nerve root to get fusion across the C1-2 facet joints. Discussed this with patients and really haven't had any issues with it. And so this patient was fixed from C1 to C3. Coincidentally, I'm yet to see him. I'm not sure if he's heading to my clinic soon. So this is the X-ray, and as you can see on the X-ray, you see there's some settling of the base of the skull into the rod, but he hasn't had any issues or neck or any occipital pain associated with that. So coincidentally, as I was putting together this talk a week ago or 2 weeks ago, I came across an MRI of the patient. He recently saw his primary care physician reporting some symptoms concerning for radiculopathy, and an MRI was obtained, and this is the MRI showing wide decompression of the base of the occiput and also into the C1-2 region, confirming the decompression that we performed. He's about 2 years from surgery now. Actually, no, it's about 4 years from surgery. This was done before COVID. It was done, actually, it was one of the critical cases that was done during the first week of the shutdown of COVID back in 2020. So this, so now this MRI that was just performed a couple of weeks ago showing adequate decompression. I'm not sure if I'll be seeing him again soon for some other ridiculous symptoms after this MRI.
So that's an interesting case, Emmanuel. I probably would have included the occiput on that. I thought there was a little bit of settling, cranial settling, but again, I think nicely handled. And I'll just answer the question that was in the chat room about when to include the occiput. I'm really hesitant to, and I try to avoid including the occiput on my upper cervical trauma cases if I can. I think it's debilitating procedure and a debilitating construct for elderly people. In addition, the complication rates are pretty high. If you look at the literature, the non-union rates are high, the rates of rod breakage are high. And I can tell you anecdotally in my career, I think I've had a long-term problem with about 40% of my occipital cervical fusions, where patients will come back years later with broken rods. Several of them have pseudoarthroses. You always worry about getting a fusion across there. We did publish on using BMP in 2 patients where we got solid fusions, but again, only limited numbers. So for me, I try to avoid going to the occiput if I can in elderly people, especially odontoid fractures. I think it's very rare that you should ever have to include the occiput in a geriatric odontoid fracture. And again, I just want to hide the fact that it is, you know, a pretty debilitating procedure for someone to live with. So that's my philosophy on including the occiput and when to do so. But in this case, Emmanuel, I probably would have gone to the occiput.
Yeah. And something, you know, to highlight when we talk about, since we're talking about upper cervical fractures and fixation techniques, either go into the occiput, or if you don't go into the occiput, as you can see on this X-ray, I left this X-ray up so you can see what can happen. As you see, the cranium is settling into, and I've seen 2 patients since I've been in practice. None, I saw them as a second opinion, who had a previous fusion and the rod was left. So there's another thing to keep in mind, even for patients, when you stop at C2 without any need to go to the occiput, to pay attention to the rod at the top of, when you stop at C1, I'm sorry, at the top, cephalite at C1, to pay attention to the length of the rod. At some patients are symptomatic from. For this patient, luckily, at least from the last time I saw him, he's not symptomatic from that rod settling into the cranium. But I've seen a couple of patients who've had symptoms from that. So it's just something to keep in mind as you fuse up to the C1 level.
It's also one of those places where you have to look at the whole spine. You know, this patient is a pretty neutral to slightly lordotic cervical spine, but in a more typical elderly patient, if he was a little clotic and he had to hyperextend at occiput C1 in order to C-suite, that might become symptomatic, you know, more for that person's alignment than for this particular patient. So, you know, in a typical elderly person who has to really look hyperextend to look neutral, it might be a bigger issue to leave the rod button up against the occiput. But you know, you got away without having to include it, and I agree with Bob. It does add complexity. Also, a lot of patients have swallowing difficulties depending on where they're locked in with an occipitocervical fusion, that you don't have to worry about when you leave it available for motion. Well, these are great cases. Good discussions all around. You know, I'd like to add a little color commentary. You know, Henry Bowman, who trained a lot of the orthopedic spine surgeons around, was a big fan of occipitocervical dislocation because he spent his research year at Hopkins in the Baltimore City morgue. He used to love to tell the story, and he hung up all the sudden death corpses by hooks and x-rayed their cervical spine. And these were in pre-CT and certainly pre-MRI days. And he found that about 30 or 40% of the sudden deaths in high-speed motor vehicle accidents were from unrecognized occipitocervical dislocation that had spontaneously reduced when they were laying on the slab. So nobody had really made that diagnosis until you know, he did that work. So, and I think you quoted like a you know, 35+% mortality rate with a traumatic occipitocervical dislocation. And when I got to Rancho, it was only because the population was being coached at that time in CPR that we started to see some of these patients come to a rehabilitation facility as a, you know, complete C1 or even higher. Because somebody gave them CPR at the scene until the ambulance got there and intubated them, where that sudden death phenomenon, you know, went down a little bit. But now you've got to handle people with an unstable proximal cervical spine and survival. And that was one of the first papers I wrote at Rancho, was just on that, occipitocervical dislocation and survival. And then what do you do with that patient rehabilitation-wise? So kind of a interesting and very sad situation, but fascinating. So, you know, thank you for taking us back through that.
You know, thank you. I think, you know, is one thing I tell the residents and the fellows every time you see these injuries is, as Dr. Molinari mentioned earlier, it's actually more scary to taking them to the operating room. You know, they need surgery, but the concern now is I could paralyze this patient who actually has a very severe injury, but is neurologically intact. And so keeping that in mind with what is using the rotisserie technique with flipping the patient, which I've used for the 2 patients I've taken to the operating, well, for two out of the 3 patients. One of them had more of a stiff spine fracture with fracture below at C2. So even though it was at C2, still considered occipitocervical dissociation because the patient had ankylosing spondylitis. And it was one of those scary cases where after we positioned the patient, which I was surprised we didn't lose any signal, but the fracture actually translated. And then it was the speed of decompression before instrumentation, which I typically will instrument before decompression. Just proceed, I rapidly exposed and decompressed the patient, and luckily the patient did just fine. So, but that's always a concern about potentially paralyzing these patients as we take them to surgery to stabilize their spine.
Emmanuel, there's a question in the chat, and they wanted to know, how do you, let's see, sorry, it was, how do you assess your fusion when you include the occiput? So what's your routine x-rays?
For assessing fusion, I've had a couple of patients that I've fused to the occiput. I think we just get routine x-rays, and just like any other patient, it's based on symptoms. We know some of these patients go on to non-union and are asymptomatic. So what do you do about it? We leave it alone. If patients ultimately develop neck pain that you're concerned that is related to non-union, then I think the next step is getting a CAT scan. I think if I understand correctly too, I think they may be asking about how do you assess your alignment of the patient's neck when you position the patient during surgery. I think, a lot of this, it comes down to, your eyeballing the patient, you're looking at the position of their head. And when you get your x-ray to get an idea as to the looking at the mandible and see if it's tucked in or if it's extended. So a lot of this ends up being honest, it comes down to eyeballing the patient and hoping that the patient doesn't wake up looking up in the sky or looking on the ground.
So I'll add to that, Emmanuel. I'm going to show my age here. One of my friends, Frank Phillips, in 1997, published an article on occipital cervical neutral. And he looked at the angle between the foramen magnum and the top of C3. And he said that should be roughly between 48 and 52 degrees. And he talked about anything excessive being excessive extension, anything less being excessive flexion. So I always get a lateral x-ray and try to assess the occipital cervical neutral angle as depicted in that article. I agree 100% with Emmanuel that you absolutely have to look at the clinical position of the head. And the way I do that is I look at the pinna and I make sure the pinna aligns with the shoulders. I make sure it's not forward, not too far extended, but you want to see the ears in pretty much in line with the shoulders. Then the other thing that you have to do that people often forget about is you have to get under the table and look up at the patient's face, because it's possible to have them rotated. Even though they may be aligned in the lateral plane, their head may be rotated a little bit. That's going to make your surgical fixation of the occiput a little more difficult, because you may be offline with the keel of the occiput, but it's also going to cause the patient to look one way or the other in your fused position. So I physically get under the table and I look at the patient's head and their eyes, and I make sure their eyes are looking at me. So I look clinically to do that. So again, x-ray, I look at the occipital cervical neutral angle, and then, I look clinically. The other thing I'll add is the guys from Harborview, Bella Barber and Brantford, have talked about the angle of the mandible being parallel to the angle of the front of the spine at C2 and C3. That's another radiographic angle that you can look at just to see if it's parallel. So I'll do those 4 things. And I can tell you, I made this mistake early in my career on an old person, an old 88-year-old guy who had a C2 fracture. And in the middle of the night, I had lost my fixation in C1. I couldn't get fixation. And I figured, I'll just go to the occiput. It's easy to do that. Putting the screws in the midline is easy. I didn't need much x-ray to do it. And I fixed the person in the military tuck position, but it was actually in a flex position. So when the patient woke up and they extubated the patient, he actually lost his airway because I'd fixed him in a flex position and he needed a tracheotomy to acutely get his airway back. So I made a fundamental mistake early in my career by not using those parameters and not taking the time to look at the head position. I will tell you, the head position is critical when you do an occipital cervical operation, because you bought what you fixed that patient in. So you have to make sure, you have to do all those things that we talked about. Make sure that that head position is in neutral, they're looking straight ahead, and the alignment is acceptable.
Those are great tips, Bob. And what was the reference again for the audience? If they want to
Frank
look
Phillips. I'm going to show. I'm going to show my age. 1997. He published in Spine. It's called Occipital Cervical Neutral. It's a radiographic study. I think it's a great study. It's funny, if you ask Frank about it, he'll say, "Oh, we wrote that up in a couple of days." But I still use it to this day. It's a great paper.
And Pierre has shared an article looking at the mandible C2 angle. I think it's shared with the panelists. I'm not sure. Is this shared?
Yeah, that's Carlo and Rick. Yep.
Yeah. So hopefully we can share this with the rest of the group.
Emmanuel, so you would brace them, and what kind of brace would you put them in? What type of?
I put them in a cervical collar, just a routine Miami J collar. It can be removed.
Even with to go to the occiput, you do that?
So for the 2 patients I've fused to the occiput, yes, but quite liberal with it. So I typically would tell the ICU, because typically you get the call from the ICU, first it goes to the resident. Can the collar come off? And the residents say, absolutely not. And then the call comes to me directly from the ICU attendant is, does this patient need a collar? And my typical answer is, no, you can take it off if you need to get into your airway or if you need to do anything. So I put them in the collar. I think part of it, is just habit. I put them in the collar, but I'm not that strict. I'm not strict on it.
So you're putting the collar in for you, whereas Bob just doesn't use a collar,
No,
right?
I told Rick, I don't waste the money on a collar. You know, it's cheap. I use a collar just for comfort. The guy, Manuel will tell you, whenever I put fixation in, I don't use braces. I don't use collars. I got the most rigid brace ever in the expensive fixation I'm putting in the spine. So I very rarely, I just use a collar for comfort. A lot of times I'll give them a soft collar for comfort.
And if you think about the fixation of the occiput is so firm, I mean, that cortical bone is so dense that you fix them to.
Again, you know, to my knowledge, no one's shown that you have to do it, and you know, it makes a clinical difference. But you know, a lot of people do it, and I think we just treat our paranoia when we do it.
No,
Yes, we're
it's like
treating
sometimes,
ourselves.
yeah, sometimes what I describe to patients is, especially during the acute period after surgery, is especially wearing the collar at nighttime. You know, you roll in bed sometimes in the middle of the night and your head is twisted. And I don't know if it helps with their neck pain when they're asleep because your head is fixed in one position and they just had surgery. I think to a certain degree, that's my thought process is wearing the collar to bed, at least during the acute period after surgery, it may reduce the risk of waking up in the middle of the night with severe neck pain because they've twisted your neck in the wrong direction after recent surgery. Does it make a difference? I have no idea.
Or then you have a non-compliant patient like that physician you had that comes in the collar upside down backwards.
Yes. Yeah.
Well, you guys did a great job. Thank you. Interesting cases, great discussion, lots of good tips and pearls, you know, for things that most of us are not going to see in our career or see a single digit number one patient. And you guys have seen a bunch. So, you know, thank you for sharing that and for joining the family here.
Thanks for having us.
Thank you. Thank you.